Just want to start by acknowledging the traditional custodians on the land which we're meeting here today and pay our respects to their elders past and present, extending that respect to Aboriginal and Torres Strait peoples joining us here today. Welcome everyone to Fertility 101 with Dr. Rachael Rodgers and Professor Bill Ledger. We're really excited to be able to bring you this information tonight, and especially I think in a conversational and informal way like this, we do really hope that you're able to take as much information from it as possible. For those who don't know who the Royal is, so a bit about us. We're the only dedicated women's hospital in New South Wales, located in Randwick. So we see a lot of patients from Sydney and the local catchment area, but beyond that, we also see patients from across the state. And at the Royal Hospital for Women, there is the Fertility and Research Centre. So the Fertility and Research Centre is Australia's first comprehensive and public fertility and research centre, opened in 2017. And so Professor Ledger and Dr. Rodgers lead the work that happens there, with a particular focus on oncofertility and genetics, but everything in between when it comes to fertility. So the way that we structured tonight's session is based on the questions that everyone submitted. So a huge thank you to everyone that did submit them, because obviously without them we wouldn't be able to have this session. So we've been able to group each of the sessions into 3 different themes. And so we're just going to step through those themes one by one, and we'll have Bill and Rachael answer those the questions that have been answered in a way that we hope we can cover off every single topic as we go. We do think, though, that there could be some questions at the end. So if your question's left unanswered or throughout the session at any time, something sparks your mind or your interest, please feel free. We had planned originally for the questions to go through just specifically to Gabrielle. However, we're, again, having some technical issues. So understand that it might not be everyone's preference to post in the public chat if they have a question. However, if you're comfortable, please pop that in there. An alternate way to ask a question, if you'd rather not that come from you in the chat, you could message the Royal Hospital for Women Foundation Instagram. Either will get through to the Q&A at the end, so that's completely up to you. I won't take up any more time, but we'll just jump into that first topic, which is going to be a bit about the information seeking and investigation process when it comes to checking your fertility and fertility preservation. So over to you guys now, Rachael and Bill.
Okay. All right. Can people hear me? I'm assuming you can.
Yeah.
So I'll kick it off and then I'll hand over to Bill. How young is too young to start looking into fertility? I don't really think that there is too young an age. I mean, obviously, you know, in your 20s, not in your teens. But in your 20s, I don't think it does any harm at all to have a look into your fertility, especially if there's any sort of suspected issue. So if you've got endometriosis, if you've got or suspect you have endometriosis with super painful periods, if you've been told that you've got polycystic ovarian syndrome, if you've got irregular periods, if you've got a family history of early menopause or anything like that, even if you don't have any of those issues, I don't think it hurts at all to go and see your GP and get an AMH blood test and make sure that your fertility is okay. For the vast majority of people in their 20s, early 30s, it's going to be absolutely fine. But we occasionally pick up people who do have a problem. And the earlier we know about a problem, the better it is. So I don't think there's too young an age to have a look into your fertility.
Great.
Sure. I mean, Rachael, that sounds good common sense. I think you're right. Most young women and men under 30 will not struggle to achieve a pregnancy, but those red flags that you raise are important for people to keep in mind. Most of the fertility tests that we do are available on Medicare. AMH, which counts the egg reserve, is not, so people will pay round about $100 to do an AMH, so that might be a downside for people starting too early. I would say have a check when you're worried, and if it's something that you want to know about, go talk to your family doctor and they can organize the basics for you. Okay, and then what age should women start looking at their fertility options? Well, I got in trouble not so long ago because I went to Adelaide to do a talk to open a new centre, and they had the political people from the state and various other worthies, and I was phoned up by the organizer to say, come and do a talk. We want you to be controversial. Well, Rachel, at least know me well. I'm never controversial. So I'm kind of sitting on the plane thinking, what shall I say? And I stood up at their meeting and I said, if I was the father of daughters, I'm not, I have sons, but if I was the father of daughters, I would want them to check their AMH for their 30th birthday. Because knowing my daughters, they'd be in the middle of their second uni degree. They probably never had a job, and they certainly wouldn't be ready to settle down and have kids. So I think looking at options, if you're not in a position to start a family, if you're not in a good relationship, maybe in early 30s, it's time to look outside the box and think about what else might be on offer. Rach, what do you think?
Yeah, absolutely. I would go even further, to be honest. I've got a daughter, and I would be recommending to her that she looks in, at least does an AMH when she's in her 20s, just to be sure that there's no problem there.
Okay. Do you want to go first on the next one?
Yeah, what age does fertility start to decline? Is the biological clock real? Absolutely. So I strangely see a lot of 34-year-olds in my practice who are freaking out because they're going to turn 35, and there's this myth that goes around that everything is fabulous until you're 35, and then something happens on your 35th birthday and it all goes kaboom and it's terrible. That's not true. The thing that happens over time is that egg quality gradually decreases over the time. So every year, egg quality and quantity decreases a little bit. So women in their 20s tend to have beautiful quality eggs. Women in their 40s tend to have really low quality eggs. And in the 30s, it's just coming down. So there's not a huge difference with any, 6-12 month period, but it does gently come down. So yes, the biological clock is absolutely real.
Yeah, of course it is. You don't fall off a cliff at 35. I agree with you. I think it's something that worries a lot of people. It's a gradual process. It's not quick. And it's also different from one woman to the next. So someone who knows she comes from a family where maybe parents, grandparents had children when the women of that generation were in their early 40s, you've probably got a better, longer fertile life than from a family where women have the menopause in their 40s. So look at your own situation. But generally, most people are fine up until their mid-30s. And even then, most women in a good relationship, natural pregnancy up until late 30s is not a struggle. Beyond that, the chance of miscarriage goes up. The risk of a pregnancy with a chromosome problem like Down syndrome begins to go up. So most of us who deal with fertility problems really like to see women and men coming in their 30s and not too much over 40 if they can. Some people get a good relationship later in life, and of course we'll try and help someone who's older, but it is going to be a bigger struggle to get a good pregnancy going.
I think it's a really difficult area because the body is designed to have babies at a younger age, and that's what society was all set up to do several decades ago. Women were having babies in their 20s. Society said have babies in your 20s. The body said have babies in your 20s, and it all worked really well. Now society doesn't say that. Women, expect and want to have a career, and that's admirable and that's great. And women want to take the time to find the right partner for them. They don't want to settle for just anyone. And all of that, the financial security, the career, finding the right person, it does take a while. And so for a lot of women, they end up in their 30s and they don't have the perfect situation to have children. And it's difficult. And I really feel for women in that situation, because what the body wants is different to what society makes easy for women, which I guess leads into egg freezing. Egg freezing, the important thing to know about it is that it's not going to be a guarantee of having a baby in the future. No matter how many eggs you have frozen, that does not guarantee you a baby. What we're trying to do with egg freezing is put the odds as much as possible in your favour to have the babies that you want to have when you want to have them. Now, because egg quantity and quality decreases with age, really the younger you are when you freeze eggs, the more eggs we're going to get and the better quality they're going to be. The flip side of that is if you were to freeze your eggs in your 20s, you've still got a long time ahead of you to find the perfect person and the perfect situation in which to have children. So there's a greater chance of you not using those eggs. But having said that, the ideal situation is never to have to use your frozen eggs, because it means that you've been able to have the babies that you want to have without needing to use those. It's a tricky area, and when we say that you should have babies young, we're talking about what the body wants and what the ovaries want, not what we acknowledge that it's not always easy to be in that situation.
Sure. And I think, Rachel, just to add to that, I think egg quality declines from about age 36, 37 onwards. So we usually would find a good number and a good quality egg to freeze for women in their late 20s, early 30s, which is when a lot of people do it, if they're not in that good relationship you're alluding to. Personally, and I think you might feel the same, I'm really reluctant to freeze eggs for women over 40 because the quality is not great. And one example of that is if you want a 50-50 chance of one baby from frozen eggs, on average age 35, you need to freeze about 12 eggs to get that 50-50 chance. Whereas age 40, you need to freeze almost 100 eggs, even just to have 50-50. So it's not practical to do that. Mm-hmm. So anyone who's thinking of egg freezing, try and do it in your 30s. But I agree, I think most young people in their 20s, they've got a lot of time to find a partner. It's not time to start worrying too much about egg freezing unless there's a specific reason for concern.
Yeah. And the other thing to think about is the number of babies that you want to have.
Yeah.
So, if you want to have 4 babies and you're 35, well, that probably isn't going to happen without some help. And then it might be a case of freezing eggs when you're in your 30s, not to try and achieve your first or second baby, but to try and achieve your third or fourth baby. So it's the whole family that you want to have really in your 30s. But sure. Yeah, but we would prefer not to have to freeze eggs for women in their 40s. But then when people in their 40 or in their early 40s come into my rooms and tell me how much it means to them to have a family, but they're single, and what do they do? It's a really difficult situation. Yeah, so we can do it later on, but they just need to know the sort of the facts that it's harder to get a pregnancy.
Okay, and then the average time to natural conception, well, a lot of young people will conceive very quickly, particularly if the woman has a nice regular menstrual cycle. She can work out when is the fertile period. It's pretty easy to get help if you use one of the sticks you can purchase from a pharmacy to tell you when you're ovulating, or there are a number of apps. Some of the apps are better than others. Be careful if you rely on the apps. We would say for a couple where the woman's under 36, a pregnancy, if it's going to happen naturally, should come within the first 12 months. If you've been trying for 12 months and there hasn't been a good pregnancy, come and talk to somebody. And if the woman's over 35 or 36, maybe don't wait that long. If you've been trying for somewhere like 6 months, come and have a talk. It doesn't mean we're going to rush into treatment, but let's go and find out the basics and maybe run some tests and see whether there's an obvious problem with either partner. Rachel?
Yeah, absolutely. That's a good general rule. I sort of say to people, if you're worried, come and see me. Sometimes I see couples that haven't started trying to conceive yet, and they just want to get everything checked out and make sure there's no big red flag. more than happy to see those couples.
Sure.
The other thing is that if there's any existing red flags, so for example, if a woman's got a very irregular menstrual cycle, say someone's only getting periods every 3 months or so, don't give it, 6 or 12 months of trying, because you're probably not going to conceive. In that case, if there's a really irregular menstrual cycle, come and see a fertility specialist at the onset, because you're probably not ovulating, and if you're not ovulating and releasing an egg, you're not going to get pregnant, unless you're very lucky and happen to have intercourse at that one that you do. Also, really painful periods, suggestive of endometriosis, if you know you've got endometriosis. If you've had any medical problems, if you've got a history of cancer or chemotherapy, if you're worried, you can see a doctor about it, and that's okay.
Good. I'm just also seeing quite a few questions in the chat. We will cover those at the end, I think, otherwise we'll lose our thread a wee bit, but we'll get to them all. Okay. And then the next one is about how long to stop birth control before trying to conceive. The mini pill, the progesterone only pill, or the Mirena contraceptive device, or a copper coil, their effect wears off really quickly. So if you stop your mini pill or have your coil taken out, have one period and then start to try. If you're on the combined pill, the estrogen progesterone pill that many women use, it's going to take a couple of months to wash out, and often natural periods don't come back regularly for a couple of cycles. So 2 to 3 months before you try is a good idea. And don't forget, in that time, do the basics. So start taking a pregnancy vitamin with folic acid, maybe see your doctor to make sure that you're up to date with your pap smear, that you're up to date with your German measles vaccination, your chickenpox, etc. A lot of good GPs will do a pre-pregnancy check with you, and it's a nice, good appropriate time to do that while you're waiting for the effects of the pill to wear off.
Yep, I would agree with all of that, Bill.
All right, good. Options for single women in their 30s who would like to freeze their eggs. Well, that's kind of where we are in the discussion. It's always saddening when Rachel or I see a couple who come in their 40s and they've fallen in love only recently. So the relationship started a bit later in life, and they will come very desperate to have family. And the options we have get less as people go through their 40s. And it's important to emphasize, it's not only about the woman either. The quality of many men's sperm goes down after age 45. So the man may have a bigger problem than he would have done when he was younger. So because we find it hard to help those couples, it's much easier if there are some frozen eggs that she froze 5 or 10 years ago when she was single in her 30s. So I think one option is to freeze eggs at that point. Going to one of the questions in the chat, the other option is to use donor sperm and either have a pregnancy with donor sperm or freeze embryos with donor sperm. The only problem there is we can't take the sperm out. So if you then meet a partner, we can't use those embryos. You'd have to create new eggs, and you might be a bit old to do that. So once you've committed to making embryos with a sperm donor, that's what you'll have stored. And we have seen people who do both, and maybe they use donor sperm to store some embryos and also freeze some eggs as an alternative option. Rachel?
Yeah, I would agree. Either of those are options. Unfortunately, egg freezing isn't covered by Medicare, so it's relatively expensive. It's obviously frustrating because it makes a lot of sense for women to freeze eggs in their 20s or early 30s. But the reality is that it's not free. But it's about, I guess, priorities in life. If having a really, really important to you, or having a larger family, then maybe you should be thinking about doing that.
Sure. Just as a caveat there, do you not think that if someone has a demonstrable cause of a fertility problem like significant endometriosis or bad polycystic ovary disease, in those cases, you can sometimes tick the Medicare box for those people because they have a fertility problem, even though they're not in a stable relationship. So I think what we're talking about is the entirely healthy younger person who is worried about the future but doesn't have a health issue. Okay.
Absolutely, absolutely. So there are criteria. Certainly, if someone has endometriosis, then I would want to have a look at their ovarian reserve. If someone's had surgery for fairly nasty endometriosis, they're the ones that we really need to see because they can have a low ovarian reserve. And we can, get Medicare benefits for that.
Yeah. And again, just one relevant question in the chat. Yes, you can freeze your eggs if you haven't been sexually active. We can do all the monitoring with abdominal ultrasound. So we do a scan just through your tummy wall. You don't have to have vaginal ultrasound for monitoring, but you would have a vaginal ultrasound to collect the eggs with the needle to the ovaries. You'd be asleep for that process, but we would have to do that. Something to talk about with your doctor if that's an option that you'd like to explore. Okay. And then Rachel, the next one is, do you have to be trying for 12 months before being allowed to do fertility checks?
No, not at all. You can come and see a doctor whenever you like. You can get a pre-pregnancy assessment. You can try for 1 month. You can try for 12. I wouldn't leave it for longer than 12. You can have a fertility check whenever you like.
Yeah. It's one of the nice things about Australian system is Medicare will cover the cost for a lot of that, not all, but a lot.
Yeah.
And one of the other things I think to point out, we're really suggesting to people that they do the screening test for recessive mutations. Make sure that you're not a carrier of something like thalassemia, cystic fibrosis, Fragile X, and make sure if you are a carrier of those things that your partner isn't also a carrier, because those couples have a chance of transmitting that problem to the baby. It's something else to do when you're planning pregnancy, but before you conceive the pregnancy. And there are several commercial groups around Australia and elsewhere that will do those tests for a couple for $600 or $700. Sooner or later, Medicare will pay for this because it's clearly a cost saving if we help a couple to have a healthy child rather than a child with a serious health burden. So don't forget to do your recessive mutation screening if it's something you're interested in.
Yeah, can be complex, but your GP should be able to explain it to you, what genetic testing you can have done. How do you start the process of checking your fertility? So on to section 2.
Yeah.
So I guess for most people, it would be to see their GP, and the basic tests for women are to have an AMH blood test or anti-Müllerian hormone. That gives us an idea of the number of eggs that they have, and a good quality pelvic ultrasound. So we would generally recommend that you go to a specialist women's ultrasound company to have a pelvic ultrasound with a follicle count. The follicle count also is another way of us getting an idea of the number of eggs that you have. And for men, it would be to have a semen analysis. They would be the basic tests. Your GP can order those and give you an idea. So that's the starting point.
Yep, agree with all of that. So the process is through family doctor. What I would say, though, is I think there are many family doctors that are really interested in women's health and fertility, and others who are more interested in other things, maybe sports injury, orthopedics, elderly people's problems, etc. So if you are going to talk to a GP, try and find someone who has an interest. Talk to friends, talk to other people who you know, and find someone who's good at this. And the good GPs can take you a long way before you need to come and talk to a specialist. So a good GP is not just about referring to someone like Rachel or myself. They can take you through all of this without having to, go to the specialist and maybe pay a higher fee and get more detailed information. So go see the doctor first, right? The next one is, I have a low egg count. What are my options? Well, that is, again, quite age specific. So if you're young and your egg count is low but not too low, maybe have a look at your life plan. When are you planning to be a parent? Do you have a good partner? Maybe talking with him or with her, you could start your family a bit earlier. So it's not necessary to go rushing off to an IVF practice. I see many people whose AMH is on the low side, but as Rachel will agree in a moment, having a low AMH does not mean you've got a fertility problem now. If your periods are regular, if you're ovulating nicely, if you're youngish, under 40, your egg quality will be okay. It's just nature telling you that none of us have an unlimited time, and your time is a little bit shorter than it should be on average. And so maybe just think about altering your life plan, starting your family a bit sooner. If you do have a low egg count, as Rachel was saying, a low AMH blood test or a low antral follicle count on ultrasound, time to talk to someone, explore what might be done and look at the options and see whether you want to do some egg freezing, or if you have a partner and you're not ready to have family, freeze embryos with him. An embryo is much more robust than an egg. It's a lot easier to freeze and thaw well. So if we have a preference, we'd go to freeze embryos, but then of course you're locked in with that partner for when you want to have your family. And as we all know, not everyone's relationship lasts forever. So think hard as to which you choose. And I can see the question coming into the chat, even if it's not there at the moment. Yes, you can freeze eggs and embryos in separate cycles. And we all see people who want to do that. How you explain that to your partner is entirely up to you, I think. Rachel, do you think that's fair?
Yeah. So I've seen a few couples where the girl wants to freeze eggs. It's a little bit, interesting sometimes. But look, yes, I see lots of patients with a low AMH or a low follicle count. And I've had a number of patients that have walked into my room. They've been so worried about this. And by the time they physically get to my office, I say hello and they burst into tears because they've been so worried about it, thinking that a low ovarian reserve means that they can't have a baby. And sometimes they've been told that. A low AMH or a low ovarian reserve doesn't affect your ability to conceive naturally. So regardless of the size of your ovarian reserve, you still release one egg each month. So it's not like someone with a high ovarian reserve releases a dozen eggs each month. That's not true. Someone with an AMH of 2 will release one egg each month. Someone with an AMH of 20 will release one egg each month. And they'll both have the same chance of conceiving naturally, provided that they're the same age. So I would say, look, if there's anything that's really worrying, you should be seeing someone about it. If you've got a lower ovarian reserve, some things can suppress it. The oral contraceptive pill is notorious for suppressing your AMH, so it might just be something that's reversible. But if you're worried, come and talk to someone, because we'd rather see you about nothing of concern than miss someone that does have something of concern. A low ovarian reserve probably means that you're going to run out of eggs sooner than someone with a higher ovarian reserve, so just be aware of that.
So pertinent to that, I saw a 32-year-old single woman a few weeks ago, and she came in a panic, as you say, very upset because she'd measured her AMH and she got a result of 2, which is very, very low for a 32-year-old. And sadly, her family doctor, who was not really a specialist, had said that she'd never have children and she'd be in menopause in 2 or 3 years. Imagine what that does to a 32-year-old. Turned out that she had been taking the contraceptive pill for many years because of painful periods. And I persuaded her to stop the pill, come back after 6 weeks, and her AMH had gone up to 20, which is perfectly normal. And so the problem was just because of taking the contraceptive pill. So as you say, you have to take these things in context and not panic before you talk to someone who knows what all of this is about. Human biology is strong, and most people, as I say, will have a good egg reserve into their early middle 30s, and then it'll gradually decline.
Yeah.
Okay. Now, Rachel, I'm interested in your response to this one about lifestyle change and nutrition that can improve fertility. We get asked this all the time, don't we?
I know. I was hoping you were going to answer this one.
I'll have a go in a minute.
So, look, there's the obvious things. Don't smoke and don't vape. Smoking has been shown to damage the ovaries. Smokers go through menopause earlier than women that don't smoke. So that's one lifestyle change. I usually say to people, be generally healthy. I don't support extremist diets, extremist. We meet people that try and follow every rule that's ever been written about what they should or shouldn't be doing about fertility or ovarian reserve. And these women, they're following so many rules that they're stressed out of their minds, and the stress is probably worse for them than anything else on that list that they're doing. So there's nothing that has been proven to increase the number of eggs that you have, and there's nothing that's been proven to improve egg quality. There's some supplements that are reasonable. The ones that I probably like are CoQ10 and NAD, but it's more about being generally healthy. So we all know what the food pyramid's supposed to look like. We're supposed to get most of our intake from fresh fruit and veggies. Don't mind too much what you put on the top, but just don't tip it upside down. Exercise is fine. Having a cup of coffee is fine. Don't have half a dozen. Having a glass of wine is fine. Don't have too many really big nights. So for me, it's more about being generally healthy and absolutely no smoking. They would be the messages that I would give. Let's hear what you say, Bill.
Well, I completely agree. I think for people who are overweight, men and women, your fertility will be reduced. It won't affect your AMH or your time to menopause, but if you're trying or planning a pregnancy, for women, getting reasonably physically fit, because pregnancy is a physical challenge. And so maybe taking a few months, not only to work on weight loss, but also general physical fitness is a good idea. Equally, many women are underweight. They exercise a lot, they diet very carefully, and they have as many fertility problems as overweight people do. Ovulation stops, periods become irregular and stop if people drop their body mass. And so it's equally important, if you're underweight with a body mass below 18, to try and gain some weight as much as losing. The other lifestyle things, I agree, the more restrictions you put on your lifestyle and also on your partner's lifestyle, the more likely it is that the amount of stress that you're suffering will increase, and that will have a negative impact on fertility. So I think we'd rather that you had a sensible but not over-sensible approach to good diet and exercise. And then finally, we see a lot of young women who are vegetarian or vegan, which is absolutely fine for fertility, except that people who are strictly vegetarian or vegan can be lacking in vitamin B12, can be low in folate, and can be low in iron. So if you are planning pregnancy and you're vegan or vegetarian, maybe see your doctor, get a blood test, and there are vegan and vegetarian appropriate supplements that you can take instead of having to think about eating meat or fish. That's not necessary, but make sure that your B12, folate, and iron are in the normal range before you have a baby, because the child that you're carrying is going to take a lot of those elements from you and you'll become more deficient.
I'm having a little bit of a chuckle here because I think Bill's talking about me, because I'm vegetarian and I've been low in B12 and iron. So yes, so very supportive of the those lifestyle choices, obviously. Yes, it is really easy when you're restricting your diet in that way to become low in the things that Bill's just listed.
Yeah.
So
it's amazing what you learn on webinars. I didn't even know you were trying for a baby, Rachel. Many congratulations. I hope it all goes well. Right, move on quickly. Okay. How do I start the process of egg freezing? We've kind of covered it. See your GP first. Medicare works through the general practice, through the primary care doctor. Do the basic tests that Rachel described earlier. Get a look at your own personal numbers, at your own individual fertility. And then your GP will help you to get a referral to one of the many fertility clinics that exist around Sydney and across most of the state. There are lots of choices. And again, one good way to find someone who you'll get along with is word of mouth. That seems to work well with many people. Your GP will have suggestions. All of the fertility companies have very smart websites. I'm never quite sure how much benefit there is there. how do you choose your motor car? All of the motor car manufacturers have great websites telling you theirs is the best car. I think it's better to talk to someone who drives one and see whether it's good or not. Rachel, any more advice about how to choose a clinic?
Oh, I think that's really probably one of the bigger ones is I would tend to go for. But you're right, they all will tell you that they're the best one in the world and all the others are terrible. But yeah, I think finding someone, talking to your GP, talking to your friends, seeing if they've got a fertility specialist that they've connected with, because you're probably fairly similar to your friends, and your friends are probably going to connect with people that are fairly similar to you. Yeah.
Okay. And also do make an attempt to do a cost comparison, especially if you are totally healthy, may not get the Medicare rebate. Different practices have different costs for these things. So shop around as if you were buying some high cost item. You wouldn't buy one from the first place you looked. So then, Rachel, do you want to talk about success rates for unfreezing eggs and embryos?
Yeah, so eggs, the egg is the biggest cell in the body, and therefore that makes it the hardest egg to freeze and thaw. It wants to form ice crystals because it's so big. So it's trickier, an egg is trickier to freeze and thaw than an embryo. Success rates of freezing and thawing an egg are probably about 80 to 90% generally. Success rates for embryos are much, much higher. I think that they're quoted at about 1 or 2% of embryos are lost in the freeze-thaw process. In my experience, it's not even that much. It's rare that we lose an embryo unless it's really poor quality. Embryos are about the same size as an egg. They just consist of about 100 cells, whereas an egg is one big cell. So we're better at freezing and thawing embryos than we are with eggs. Yeah.
So yeah, I mean, eggs are fragile and they're brittle. They're hard to freeze and they're hard to thaw. So for me, suppose we're talking about someone who's age 35, I'd say 12 frozen eggs would be the equivalent of maybe 3 frozen embryos at that age. It just shows you how much more robust the embryo is. And that's in terms of having a good pregnancy. 12 eggs give you a 50-50 chance of one healthy baby age 35, and at age 35 you would get that 50-50 chance from about 3 embryos. And don't forget, we can never give a guarantee. It's never possible to be 100% certain that someone, even with 30 or 40 eggs frozen, it is going to work for them. Yeah. Rachel?
Eggs are a little bit of an unknown. So when we get eggs, all we look at is, are they mature? And if they are, we freeze them. Whereas, and that's, there's no quality test. And we haven't even introduced sperm into the equation because the quality of the sperm makes a difference. When we're creating embryos, the egg has to be mature, it has to fertilize, it has to grow for the next day and survive in the incubator for the next 5 days and be suitable for freezing. So to become an embryo, an egg has to leap over all of these hurdles. It really gets tested. So there's much more certainty about the likelihood of pregnancy with an embryo because we've already effectively tested the egg and the sperm. Yeah. With an egg, we don't know the quality of the egg. We can only go on age, and we don't know the quality of the sperm. You might not have even met the guy involved. So, yeah, there's a lot more certainty about freezing embryos. But like Bill said earlier, you can't unfertilize an embryo and take the egg back again if you find a new partner.
Okay. And then how often should I check my fertility if I'm looking to have children in my mid-30s? I mean, people vary on this. If you have a good AMH at 35 and the rest of the tests are normal, you have a good ultrasound, then a couple of years would be fine unless you have a health catastrophe. When you get to 37, the drop-off in egg quality, egg number may go a bit quicker. So just maybe repeat an AMH or an ultrasound every year or so. And don't go much beyond that age without thinking about freezing eggs if that's your only option. it's something not to do, as we've spoken earlier, much over age 40 if you can help.
Yeah, I would agree with that. And if you're thinking about having your first child in your mid-30s, also think about, are you thinking about having a second or third child, and how old will you be when you're having those children? But yeah, I would agree with Bill. Every couple of years if everything's great, but if there's any concerns or you're anxious, every year. How long can eggs stay frozen? Theoretically, as long as you like. I sometimes joke that if someone freezes their eggs when they are 20, we could get them pregnant when they were 70. And not that we're going to get 70-year-olds pregnant. We really that. But theoretically, we could do that. The eggs, once they're in the freezer, or the embryos, once they're in the freezer, they're effectively frozen in time. So if you freeze eggs or embryos at 25, you could certainly use them at 35 or 40 or even 45.
Yeah, in the US, women are bequeathing their frozen eggs to their daughters. So if the daughter has a fertility problem, in theory, she can give birth to her own sister, which is very strange. I've not seen that done in Australia, but it shows you how long they can last. And they're frozen in liquid nitrogen minus 193, not in a domestic freezer at -4. So you have to freeze at minus 190 to get that very, very long life. Longest I've seen someone have a baby from a frozen embryo was after it was frozen for 23 years. And she had two little girls, one after 21, one after 23 years. Children were fine, just had a lifelong aversion to ice cream. Very bad dad joke. I apologize for that.
If
All
anyone
right.
the Bill, you will get the dad jokes. I have to warn you.
Yeah. So I come with a health warning. So Elise, I think that's the end of section 2. Is it okay to go on to section 3? We've still got a bit of time.
Yeah, absolutely. We'll jump straight into that. We are running a little bit behind, so hopefully we can catch up.
Of course we are. All right.
Okay. Options for 37 to 40-year-olds looking to become pregnant. Try and conceive naturally. If you have any concerns, like we said earlier, irregular periods, endometriosis, medical conditions, see someone straight away. Otherwise, maybe try for 6 months and then come and see someone if you're not pregnant.
Yeah, and I think similar answer talking about the implications of endometriosis and adenomyosis. These are disorders of very variable penetrance. So some people have a mild form of endometriosis, not much effect at all. Others have devastating disease with big ovarian cysts, a big loss of ovarian reserve, impact on fallopian tubes and natural fertility. If you know you have endometriosis, more than likely you've seen a gynecologist already to have that diagnosis. You may have already had a surgery. So maybe go back and talk to them as a first port of call, and then come and see someone to look at your own individual circumstance. It varies a lot from one woman to the next about how serious the endometriosis effect is. And often we'll do laparoscopic surgery because of pain and inability to work and live well because of the problems of recurrent pain, and at the same time can make an assessment of fertility, so we can kill two birds with one stone, so to speak.
Yeah.
Rachel, do you want to do the PCOS one?
PCOS, it's people worry about not being able to have a baby. It's one of the better problems. Some people will be told they have PCOS, then they'll jump on Google and see that it's linked to infertility and think that they won't ever have a baby. The problem with fertility as far as PCOS is that often women aren't having a regular menstrual cycle and therefore aren't releasing one egg each month. They might be having a period every 3-6 months and then only releasing an egg every 3 or 6 months. It's relatively easy to force the ovaries to release an egg. It's called ovulation induction. So people with PCOS generally have lots and lots of eggs. The ovaries just a little bit reluctant to release them. And we can force that issue for them. IVF is a backup, and people with PCOS tend to go quite well with IVF. So I wouldn't get too worried about PCOS and fertility.
Yeah. Ovulation induction can be done either with medication tablets of a drug called letrozole or Clomid, or injections once a day for 2 weeks. Talk to your specialist and find out how the best way is to do it for you. And then, is it more difficult to have children over 35, and what are the impacts? Well, we spoke quite a bit about this. It's just one of those sad things in nature that even though in many ways a 35-year-old is a young person, you're not anywhere near halfway through your life. Fertility problems become more difficult as you get towards an over 40. So it's not only that getting pregnant, miscarriage rate goes up and chromosome problems like Down syndrome go up as well. So if you are someone who's thinking about being pregnant later in life, go for it. By all means, talk to someone, maybe have some help, and just look at all those problems holistically. Getting to the point of having a healthy child, as Rachel said earlier, you have to jump over quite a lot of hurdles. We're here to help. Okay.
I think just the actually carrying the pregnancy. At 35, it's fine. Late 30s, it's fine. But really, when you get into your 40s, it starts to be a bit more risky. And certainly over 45, the risk associated with carrying a pregnancy can be quite significant. So again, it is that time pressure to have babies in your 30s or at least your 40s.
And then, Rachel, do you want to do the next one about keeping eggs healthier?
Yeah, so kind of what we said earlier, don't smoke, don't vape, be generally healthy and try and keep your BMI within the normal range. They would be the big things.
Yeah. The next one is a good one, actually. Can I still get pregnant with only one functioning fallopian tube? So many young women will have an ectopic pregnancy, will lose a fallopian tube because of that, or maybe have an STI, which causes a tubal blockage. There are other reasons that you can have a blocked tube. You can be born with only one fallopian tube. And the body is a clever thing. So you can ovulate from the left ovary, and the right fallopian tube can come across and collect the egg. So even if you know you've only got a right fallopian tube and you ovulate on the left that month, it's still possible for that egg to become an embryo and to give you a pregnancy. So yes, it's perfectly possible. Someone who's lost a tube with an ectopic pregnancy is at a bigger risk of having another ectopic pregnancy than someone who's never had one. So if you are in that situation, have an early ultrasound to make sure that the pregnancy is in the uterus in the right place and not in the tube again. Okay. Anything you want to add, Rachel, to there?
Yeah, so the chance of conceiving naturally with one tube is a little bit less, but it's not reduced by 50%, because strangely you can ovulate on one side and the other fallopian tube can pick the egg up. Yeah, kind of cool. But yeah, so I wouldn't get overly worried about that. But Bill's right. If you do conceive, have an ultrasound at 6 weeks to make sure the pregnancy is not in the tube.
Yeah. Do you want to take the next one, Rachel?
Oh, it's a big one, isn't it? Secondary. Why do some people have their first baby easily and have trouble having a second baby? Oh, there's a lot of reasons. One of the most common reasons is that people are just a bit older when they have their second baby and egg quality's gone down, and it just makes it harder to get that good egg and conceive. That's a big reason. Sometimes people have developed endometriosis or adenomyosis, they've developed fibroids, or they've had those conditions and they've worsened over time. Sometimes people have had other health events in their life that makes it more difficult. But yeah, there's a lot of reasons, but age is probably the biggest one.
I think the other thing is to look back at the pregnancy and the childbirth. Not infrequently, you'll hear someone who had maybe a difficult cesarean section in labor because of fetal distress, maybe close to full dilation of the cervix, and it's done quickly in order to save the life and health of the baby. But it's possible after a difficult C-section, there's residual damage to the uterus where the repair was made, where the cesarean was performed, and that can be looked into with ultrasound and can be repaired. And sometimes someone has had problems of infection if the waters have broken early and there's been days or weeks before the baby's born when there's a possible infection in the uterus, or there's been some damage to the cells that make the lining. So one thing that you may notice is that your period is much lighter than it was before the first baby came along, suggesting there might be some internal damage within the uterus cavity we can check that out again with ultrasound or with a minor surgery called a hysteroscopy. So it is complex, far too complex to go into in a couple of minutes in detail, but someone who's finished her breastfeeding and her periods have come back naturally and is not conceiving over a few months, worth going to see the doctor and getting a checkup. And most of these tests are fairly straightforward, not very invasive and not painful. Okay.
So, Bill, that might be a nice segue into our open questions. We've had actually quite a few come in around breastfeeding and possible sort of infertility or fertility struggles during the breastfeeding period, or post or trying for a second baby. So if you wanted to sort of open the floor to that.
So we've evolved from the time when it was important for mom to be able to physically protect the newborn baby and the young child from saber-toothed tigers, and when we were living in caves. And so when you're breastfeeding, you make a lot of the hormone prolactation, and that naturally switches off the ovaries from making eggs. So those women don't have periods when they're breastfeeding, and many people will tell you that for the first 6 months after the baby's born, you've got to be breastfeeding pretty much continuously without using solids or bottle. If you introduce solids or bottle feeding, often the prolactin level goes down, ovulation will come back, and you ovulate before the first period. And how many people do you know who fell pregnant quickly because they thought breastfeeding was protective and it wasn't? That can happen, okay? Once you are breastfeeding less than 100%, it's variable how quickly your ovulation comes back. And Rachel and I see women who breastfeed until the baby's 2 or even 3 years of age, don't have regular periods, can't get pregnant again. And then you have a dilemma, because it's often very rewarding both for the mother and the child to breastfeed, but it's maybe time to think about weaning the baby to release your body from that inhibition of the prolactin, let it ovulate naturally, and have another pregnancy before you get too much older. Not something necessarily that you need to see a specialist about straight away. Your GP can advise. If your periods come back regularly, you're probably ovulating. Just be aware there might be something else wrong, as Rachel was talking about before. Rachel, do you want to add to that?
No, I think you covered it pretty well, Bill. Should we leap into other questions? Do you want to choose the questions, or should we?
We've had a few come through actually surrounding medications and fertility. So the impact of medications like antidepressants, stimulants, other supplements or medications you may be on when trying to conceive, and how that can affect the conception process.
Yeah, so look, there's a service. It's a big question. There's, thousands and thousands of different medications out there. A lot of them are harmless, some of them are harmful. There's a fantastic service that's run out of the Royal Hospital for Women called MotherSafe. So if you have a question about a medication, you can Google the word MotherSafe, and you'll get the contact details. You can ring up and ask your question, and if it's a simple question like, is Panadol harmful, they'll go, no, not at all, and you'll have your answer. If it's something more complex, then they'll bring you in for a proper consultation, and you can get the answer. As a general rule, the time when we have problems with medication is in the first trimester of pregnancy, because that's when the baby's limbs and organs are forming. And if there's a teratogenic medication in the mother's bloodstream, it can cause a problem there. It's harder to know with egg freezing. As a general rule, we don't stop antidepressants. It's a risk-benefit kind of thing. Egg freezing, I don't think really antidepressants have any impact at all. In pregnancy, they can have a little bit of an impact, but they're generally, as this is really generally speaking, that they're okay. Stimulants, would have to know exactly which one it is, but probably they're going to be okay for egg freezing. But it depends on the particular one. But any questions in that regard, call MotherSafe. It's a free service.
Yep.
Okay, I think we've got time for one last question. Going back to preconception testing, are there any tests that male partners can be doing at this point, and how do they sort of access those services?
Sure. Well, and the obvious one is to do a semen analysis, a sperm test. And again, your GP can refer you for that. It's a good idea for the man not to ejaculate for 2 or 3 days before he does the test, but it's a bad idea for him to save up the sperm for 2 weeks. If you keep them for too long, they're not motile, they don't move properly, and then you get a worrying result, which is not correct. So 2 or 3 days before, and then the sperm test, generally they like the man to go to the lab, and there'll be a quiet, discreet area where he can produce the sample, but it can be done at home. It always amazes me how much drama some men can make out of this. I mean, the poor woman's having surgical things and ultrasounds and all kinds of blood tests, and all he has to do is produce the sperm sample, and it becomes the most major exercise. Be sensitive. It is something that men feel quite deeply about. And the drama when Rachel or I have the result in our hand and he's kind of waiting to hear. A good result generally makes a man at least 4 centimeters taller immediately. It's amazing how the impact is. And equally, a bad result, even with someone who's emotionally strong and tough, it hurts. And so if you're the partner of that person, just be aware that even though, like most men, he might not be very emotionally outgoing and willing to share, inside it's a big thing. So be careful with that. If we do get a result that's suboptimal, almost always you'd want to repeat it a few weeks later to make sure it's a real result. If someone's been out on a big stag night or has been, I don't know, using things that are harmful to sperm, that will show up in the sperm test several weeks later. Same if he's had an illness, a viral illness. It used to be COVID that affected sperm quality. When the man got better from COVID, the sperm improved. So don't read too much into a single result. It's also possible for the man to do hormone blood tests, similar to what the woman can do, to make sure that he's got the normal hormone drive to make the testicles make the sperm properly. So as a basis, that's the kind of thing a GP can do. Rach?
I think the only thing to add with all of that, and as a general message, is if you get a result and you're worried about it, rather than freaking out and going to the place of, or leaping to the immediate conclusion that you're never going to be able to have a baby, come and talk to someone about it, because often we know either how to fix it or how to get around it. So many people I see have just become, they've had a terrible time. They've got that result until the time they've had a proper chat, they've been so worried and so upset and so anxious. And then I'm able to reassure them. So if you get a result that's got you worried, then come and talk to someone before you freak out.
Gabrielle, can I just very briefly address 2 more questions that I can see on the list here that I think have a relevance to the audience. Firstly, someone says that her husband's sister has positive for the gene for cystic fibrosis. Is there a chance he might have the gene too? Yes. And carriers of these things are usually healthy. You don't get a clue in your own health because you have the one, if you like, bad gene for cystic fibrosis, but the good gene that you have, because you're a carrier, protects you. But if you do have the bad gene, like your husband may have, and if the woman has it as well, both bad copies go to the baby, then you've got a big health problem. So that is definitely worthwhile checking out. And then finally, how can you ensure that ovulation is occurring? Well, most women with a regular cycle will ovulate regularly. You can measure progesterone in the second half of the cycle or buy over-the-counter tests that will tell you for sure.
They're exactly the 2 questions that I was going to say that we should answer before we finish. Obviously, great minds think alike, Bill. The other thing with ovulation is one of the really good tests is simply the question, do you get a period every month? And if the answer is yes, you're probably ovulating every month.
Great. All right. Well, I think, we've got through everything and we're only a little bit over time. So we can wrap it up there. But thank you so much again for your time. We're very grateful for you guys to offer us all of this very important information.
No worries. Pleasure.
Okay.
Good.
Thank you very much.
Okay. See you.
Bye.
Bye now. Bye.